Thank you so much for joining us for our April SimCity rounds. My name is Dr. Petal Abdul, and I'm the faculty lead for simulation education integration here at the Temerty Faculty of Medicine, University of Toronto. I'm really excited because we have our first speaker from the Department of Obstetrics and Gynecology here at U of T. And so it's always wonderful when we can showcase all the innovative and advancements that are happening in each discipline here in medicine, in the Faculty of Medicine. So we're at 12:03. I'm going to give people probably one more minute to wander in, and then I will introduce today's speaker. Hi, Lisa. All right. So today, month of April, we have Dr. David Rojas. He's the Director of Program Evaluation and Medical Education at the Temerty Faculty of Medicine. And he's also a scientist at the Wilson Center at the University Health Network and an assistant professor in the Department of Obstetrics and Gynecology at the University of Toronto. His work focuses on medical simulation, program evaluation, and educational innovation in health professions education. He is also an evaluation consultant to the Royal College of Physicians and Surgeons of Canada and is the founder and CEO of Proximity, and that's spelled Prox, capital SIMITY, for those of you that want to look that up. And it's a company developing advanced simulation technologies for healthcare training. So, David, thank you so much for making the time to present to us today, and the floor is yours.
Thanks a lot, Petal. Let me share my slides, and then we can get this started. Okay, perfect. Well, thanks a lot, everyone. Good afternoon. Thanks a lot to Petal for the kind introduction. So, for the presentation today, I really want us to, or I really want to invite us to think about the different constructs that will influence medical simulation and where does Fidelity lands. And as a matter of background, I wanted to disclose that I'm an engineer, and I've seen and lived through simulation across the simulation continuum, I call it. I went from developing tax trainers to developing virtual reality simulators, to designing the educational component of the simulation experience, to now be in a position where it's more about determining whether something is working or not and why it's working. And through all that, the one pattern that I always saw is that we care a lot about the fidelity portion. How does it look? Like, does it replicate these particular characteristics that we're looking for? And perhaps the argument that I'm bringing today is not to stop thinking about fidelity, but to think about beyond fidelity and going back to the educational foundation that our simulation experiences are usually based on. The power that instructional design can bring to our simulation experience, aligned with the fidelity levels, will definitely find the efficiencies that we're looking in medical simulation. So I have prepared a conflict of interest slide, as Petal mentioned, but the one way that I will address my own bias is by not making any reference to any particular product or simulation or the products resulting from my work in the Royal College. And I wanted to start today by testing the waters. As you guys can see on the screen, there's two options. There's the high fidelity, and perhaps not as much as high fidelity, but it has a lot more of the characteristics that replicate a procedure. Then on the other side, you have a low fidelity tax trainer that are used for the exact same procedure. And for me, the main question is, which one is better? Or which one leads to better learning? And I was wondering if, for those that are attending, like, we can perhaps on the chat just drop down, which one do you guys consider that is going to be better for learning? not all at the same time, but
It depends.
thank you, Lisa. Of course, I can rely on you. Lisa's right. She took exactly the next part on the slide. It's never A on B, but it really depends. And the main reason why I bring this example when I give this presentation is because it depends on the educational outcome that we're trying to get and how are we going to get there. So it's less about the fidelity of the simulator and more what we want to do educationally with that particular sim. So for today, I wanted to perhaps come to a consensus agreement on when simulation actually works. And I'm not saying that simulation works because that work has been done several times and we know that it works. So just by looking at the number of simulation labs that we have across our Toronto hospital infrastructure, by looking at the number of simulation offerings that exist nowadays and continue to grow, we know that it works. But for me, the most important part is not does it work or not, but what is the secret sauce? What makes it work over something else? So after that, I'm going to bring us back to the idea of fidelity and is the fidelity enough when we're thinking about medical simulation? And I then will propose a different way to think about the designing of simulation and how bringing the educational to the forefront, we can probably reach better outcomes. And I will finish with some research projects that I've done in the Department of Obstetrics and Gynecology around medical simulation to further emphasize the point. So when does simulation work? And in order to make this argument, I'm going to bring the work of 4 foundational papers that we have in medical simulation, starting with McGee. And what I find very interesting about the work that McGee did is that she was trying to really compare, well, what happens when we have simulation-based medical education with deliberate practice against traditional clinical education. And back at that point was just a more occasional interaction or occasional exposure to the simulation for the trainees. And I believe she did an analysis from 1990 to 2010. And out of those articles, she only found 14 that were able to speak to that particular phenomena. And when she analyzed those articles, there was a range of learners and a range of skills, resident, medical school, clinical fellows, and everything from ACLS to cardiac auscultation to racentesis. And what was more interesting of all these is that the overall effect size was around 0.71 with a 95% interval, which really what was telling us is that simulation becomes a lot more powerful when it incorporates elements of a repeated practice or structured practice, in this particular case, deliberate practice, compared to just the occasional exposure to the simulator, which in theory kind of makes sense, but in practice, we see that there is a lot of simulation experience that sometimes don't have that educational foundation. So that analysis of deliberate practice is what McGee is bringing to the table. The next one that I want to talk about is Eisenberg. And what Eisenberg did was, okay, let's move away from that simulation work to under what conditions that simulation work. And he, similar to McGee, did a review also from, I think, the 1970s to the 2000s. And out of that, he found 109 independent studies that met his inclusion criteria. Then he started identifying what were the factors that were helping high fidelity simulation to lead to learning. And his results that are highly cited actually suggest that for 47% of those articles that met inclusion criteria, feedback was cited as the single most important feature of the educational the simulation experience. So we know that, and to a lesser extent, but very similar to the work that McGee was doing, is the idea of repetitive practice. So we're realizing that it's not just a simulator that as a magic machine will transfer the skill, that there has to be a structural educational approach to use that particular simulator. We need the feedback component to be able to inform that particular simulator. And then the last piece I wanted to bring is the work that Seymour did back in 2002. And for Seymour, really what he was trying to show people is what happens when you train freely in a simulator versus when you train to a specific target criteria. This is exactly how you need to get, and you continue to test and test and test until you get to that level. So what Seymour did is he actually brought 16 surgical residents. I believe he was trying to teach them laparoscopic cholecystectomy. And then on a double-blinded trial, he was able to identify that those that actually had the target criteria or the target training actually were a lot faster and the number of errors reduced, I believe they call it in a six-fold compared to the other group. Yes, the study was done in VR, but the main element, it wasn't about the VR element or not. It was about the fact that in VR, there was a specific target of performance that the trainees needed to acquire. That's what same was bringing to the picture. If we actually not only just structure the repetitive practice and providing feedback, but we'll also clarify what are the objectives what we are trying to get into that simulation experience. That's what we're trying to maximize the simulation overall. And of course, when we start looking at all these different elements, we realize that the effectiveness of the simulation as a learning experience is really underpinned as an educational machine, in which we need to have the clear objective that Seymour was suggesting. We need to have the structural repetition, as Maggie has suggested, and we need to have a feedback provided, as Eisenberg has suggested, which in reality, what it aligns with is the theory of Erickson about deliberative practice. And Ericsson actually didn't write on the simulation sphere. Ericsson wrote it on the educational side, but what he proposed is that superior performance develops through the practice, and it's not just a matter of innate ability and then just experience. It has to be very deliberate. It has to be effortful. It has to be goal-oriented. It has to be focused on improving specific skills of the performance over a period of time. And he also selects the foundation that is not just for acquiring the skill at the beginning, but also for maintaining that skill on continued professional development. So when we realize the ultimate goal of medical simulation, that is that skill transfer into real life, we need all these other blocks to come together to be able to provide that foundation. But David, we heard the idea of more realism might lead to actually better learning. And that was the one piece that was missing. We have the instructional design, but now let's go back and talk about like how the simulator looks. And what is important is that actually some of my colleagues, Jeff Norman, Kelly Dory, and Lawrence Grierson, wrote this review in 2012 when they were trying to compare high fidelity simulation versus low fidelity simulation on measures of clinical performance. So not a satisfaction or perceived realism, but actually what happened when you were having to do the skill. And what they found is that the high fidelity simulator and the low fidelity simulator, they were very consistent or very inconsistent advantages of the high fidelity simulator or the low fidelity. This amounting sometimes to only 1% or 2% of efficiency. And rather than thinking that the line between a skill acquisition and fidelity is straight, what Norman and Dora and Gerson actually suggested is that it actually reaches a plateau. There's an element in which it doesn't matter how much of fidelity you add to your simulator, your still the educational gains are going to be the same. So adding more realism at that particular point, what really ended up doing is overloading your working memory. And then at that point, you get into a cognitive overload that will limit the educational gains that you will get if the level of fidelity was more aligned with the educational design. So if fidelity doesn't explain learning, then what does? And bringing again the foundation from Eisenberg, McGee, and Seymour, I say that simulation is not just realism and technology, is the intentional design rather than learning and feedback. And this is what I start bringing the education at the foundation of the effectiveness of our simulation experience. Design matters more than the realism that our simulators will have. So if design matters more than the realism, so how do we go from the idea of fidelity to this purposeful design? How do we transfer from thinking about how good they look to how do we better use it? And what is interesting is that when we think about simulation, it's sort of intrinsic that we start thinking about how we're going to measure it. So that's what I started with the slide of how we're going to measure it. Because if we think about a fidelity-driven approach, we're usually looking at, is it real or does it look real? And traditionally, the key metrics are face validity or trainee satisfaction. But if we shift the mindset and we start focusing on the design-driven approach, then the core question is not about like, does it look real, but does it teach the skill? And to what extent it does teach the skill. Then we go into the construct validity. And for the construct validity, the main element is, are we actually learning what we're supposed to learn? And is that skill actually being transferred? And When we start seeing the differences at the measurement level only, the fidelity-driven approach focused on the hardware and the aesthetics, and the design-driven ended up focusing on the curriculum. Now, the caveat in here is that when we are doing this validity analysis on our simulators, the phase validity level is the foundation for the other levels of validity. And I will talk about the other levels of validity in a second. But I wanted to look at the other side of the coin as well. So this is how we measure if we shift our paradigm from fidelity-driven to design-driven. But how about the design element itself? And here is what I feel that the pillars and the foundations need to all align. We need to start thinking about the learning objective, as Seymour has suggested, because with clear learning objective, you actually reach a much impactful educational outcome. We need to follow the idea of start repetition, as Erickson has suggested and as McGee has identified in her review. And we need to bring the idea of the feedback mechanisms, as Eisenberg has suggested, as one of the main components. And only with this particular alignment, the educational structure doesn't fracture. Otherwise, you might get into a situation where you get the results and then you might not get the outcome that you wanted, or you might get the outcome that you wanted, but you are not able to identify how are you particularly reaching that outcome. So what I think is that, or what I suggest is that simulation should go from the old questions that is it realistic and face validity to the construct validity. And the one caveat that I will make in here is that doesn't mean that this doesn't happen yet. But usually what happens, and here is where I bring a message validity framework, is that I see this as a funnel. So we go through the first layer, we do face validity, we know the simulator is working, that's great. It looks like what it's supposed to look. And then we go into content alignment or construct validity. And the challenge in here is that sometimes we focus on, does the simulation help us with learning? But in order to know whether the simulation helps us with learning, we need to know whether the simulator is able to differentiate between a novice or an expert or true performance in the simulator, like those differences are apparent. And then sometimes the work ends there. My push is that there's an additional element when we think about validity, that is like, what is the educational impact that that particular simulation is having? And this is all by the four levels of validity that Max is suggesting. And the invitation is to continue to push beyond that phase validity level, understanding that the phase validity level is needed as a foundation. But the other element that I wanted to bring today is that when we're thinking about fidelity, I see this kind of in two different axes, and we can break fidelity into two particular concepts. And this is the idea of the psychological fidelity that really focuses on, does it act real? Does it feel like what we're going to be doing in the real life? And then the engineering fidelity, that is more the look. Does it look real? Does it help with what I'm supposed to do? We can have the highest fidelity of the simulators, but if the experience for the trainee is not aligned with what they're going to be doing in practice, we run into the concerns that are raised around simulation about learning the wrong thing and then performing erroneously. But I believe that purpose design is how do you operationalize this validity argument within simulation. So bringing those educational core components at the design level is what's going to help us move forward. And here I have two case studies to further emphasize this work. The two case study, the reason why they fit with this particular rhetoric is because they were designed for the task. They weren't designed for the look. So we knew what were the tasks that we had at hand, and then we decided like, okay, here's how we're going to design our simulators to be able to meet that. And I'm going to be talking about two procedures in obstetrics. One is the horses-assisted vaginal delivery, and the other one is the twin-twin transition syndrome. And I'll go in a second in detail and show those. Before that, I wanted to mention also how we're bringing the different educational pillars from Seymour and from Eisenberg and from McGee into the design. The first layer, and in both of the simulators that I'm going to present today, they were created with the idea of using virtual reality, either as a mixed reality opportunity or as a full virtual reality opportunity. And the main reason for that is because in the visual layer, we were embedding what Eisenberg has suggested around feedback. But feedback can come in many different ways. And what we were thinking is that we were going to overlay anatomical cues on our models using virtual reality as a way of providing immediate feedback to the trainee that was practicing the skill. We also understood that there was a need for a physical interface that the trainees can interact with. And then on the tool, we added a series of sensors and technology to be able to measure their performance, track their deliberative practice approach, and then being able to provide objective feedback. So we're trying to bring the educational pillars that we have talked about into the design of our simulators. And let's work into the first case study, the Forces Assisted Vaginal Delivery Program. So, of course, this work is not done just by myself. I did it with my colleagues, Sebastian Hobson, Albert Uribe, and Fabian Gualdron. And when we think about what is the forces assisted vaginal delivery, this is the type of delivery in which the obstetrician uses forceps to be able to help on the fecal extraction of the baby. So I know it might sound atypical, but sometimes, depending on the conditions of the delivery, we might need a little bit of help to be able to get the head of the baby through the birth canal out. Now, why does it matter is because the skill is declining. And not only based on the work that Rose et al. Did in 2021, where she showed that actually around 60% of the residents, PGY4 residents in obstetrics, didn't feel confident to be able to perform the skills without supervision. But the other element is that this procedure is usually used as an alternative sometimes for those emergency C-sections. And we know that when a C-section is planned, there's a lot more safety. But when it's an emergency C-section, there's a lot more risk, and it can end up in morbidity, which we argue that if we have more of the forceps-assisted vaginal delivery, then we will have a reduce in those particular rates. But the problem itself is that there was no realistic simulator for the trainees to be able to practice the skill. The skill itself is actually quite delicate, but the main element, let me just choose the slide that I really want to get at, is that the position of the baby's head and the position of the forceps around the baby's head is one of the key elements. Otherwise, when you start putting the pressure to be able to help the baby come out, it's going to end up damaging or affecting the baby. So what do? We realized that the problem in reality was the gap in training strategies. We knew that we have, of course, a result, low levels of confidence, reduce of the procedure being performed in the hospitals. We have increased in the use of C-sections, and that has led to higher morbidity rates. So the solution really was going the simulation training role. But the challenge that we saw is that for the physical mannequin, they were actually like quite expensive, and they weren't quite offering the level of feedback and the level of interaction that the trainees needed. And the way that the subject matter expert measured in this particular case was when the forceps were introduced around the baby's head, like could the forceps just stay there? And on the commercial model that we had available at the time, like the forceps would fall. He was suggesting that that was one of the main flaws because that's not what happens in real life. So for us, we were thinking about, okay, let's develop a simulator, but also let's add all the educational design elements that we know that are going to help us with the educational outcome. And we landed on virtual reality, given the benefit that it has on the provision of feedback. But the main challenge, if you think about virtual reality, or if you have ever used one of those helmets, is that the helmet actually comes with controllers. And the controllers are different than the forces. So if we're going to be using the helmet, we need to place the anatomy structure over the model that we wanted. Like, how do we tell the headset, like, this is what we wanted without having the controllers? So what we did is we actually created a way to align the controller with the forceps in a way that wasn't invasive for the person that was doing the procedure to be able to overcome that main limitation of VR. And the other element is that we decided to compare it. What VR offers is a much faster way of reproduce different scenarios. But on the other side, like if we were able to just practice the procedure using VR, it's all great. We'll just address the limitation on training. But what is the element that the haptic feedback is bringing in here? So for us, really, the question was, how does the touch representation through a tangible use interface impact, and we measure usability, cognitive load, presence, and educational value of the forces assisted vaginal delivery. As I showed you before, our students developed the full model. This was actually an electronic arm that they developed that was able to like replicate the forces of pulling the baby. It was also able to rotate the baby's head, that were one of the conditions that are needed for this particular procedure. And it was all very low cost, made out of low cost electronics. And on the other side, for the VR, this is what I've been suggesting. So on the left side of your screen, you guys will see a 3D printed model with silicon, and then there was a overlay of the anatomy of the bone structure as well as the fetus. So the trainees will see when the forces were coming in, where the forces were landing. And on the one on the right side is a very similar representation, but now there's no physical model. It's all on VR. And the last piece, because again, what Eisenberg was suggesting was feedback. So we look at feedback in two different ways. We look at feedback on performance metrics such as time, angle, and displacement. But we also look at feedback in terms of the delivery path. And the idea of the delivery path was something that previous work around this same procedure has shown that the perfect way to complete the procedure, it follows a particular path on performance. We're able to replicate that path, and I will talk a little bit about the differences and results. So for our study, of course, we first collected some demographics. We brought different levels of expertise from PGY1 to PGY5. We did a counterbalance design in which we asked the trainees to first interact with the mixed reality version, complete some of the questionnaires for the recollection, and then the virtual reality, and vice versa. We asked, randomized it, and asked some trainees to complete the VR first, and then the mixed reality simulation. And here's what we actually found. So when it comes to usability and presence, the mixed reality simulator scored better compared to virtual reality. Cognitive load, understandably, it was lower when it comes to the mixed reality simulator, only because it was more natural for the trainees to be able to use it. The VR increase in cognitive load can be attributed to some of the complexity of being able to know where to place the forceps if there was no model for the forceps to be placed. However, that was not significant, not statistically significant. We also look at realism, self-efficacy, educational value, and overall experience through validated questionnaires. And in all those, the mixed reality version actually performed better than the virtual reality. And the one element that we find very interesting is that on the left, you guys are seeing the path or the performance of an expert on this particular procedure. On the right, you're seeing the performance of our trainees. And the top one is the mixed reality one. The bottom one is the virtual reality one. When we look at the smoothness of the path, when we were first starting to analyze the data, we thought that the virtual reality condition was actually more similar to the one that the expert has created, and compared to the mixed reality that we see a lot of variation. But actually, when we review the videos that we had of each of those sessions, what we realized is that the smoothness that the expert has is because when the forces are introduced and you're trying to help the baby come out, when you are a novice, you don't know how to smoothly perform it, and you start janking it up and forth. And that's what we're seeing on the graph. So even though at a data level and a look level, the virtual reality was delivering a better or a more aligned pathway compared to the expert, it ended up being the mixed reality one that it was more aligned with the task. So if we're thinking about the idea of the clear objective that Seymour has mentioned, as I mentioned at the beginning of the presentation, the mixed reality one is the one that is providing us that. So how do we bring it all together in this particular study? We knew that usability was similar. We knew that there was a level of immersion and higher difficulty when it comes to the hybrid, as shown by the graph that I just explained. But the main learning piece for us through this particular experiment is that we can get to a level of desirable difficulty that it might be actually beneficial for the trainee. And that's what the haptic element was adding to the trainees. It was giving not only the sense of realism for placing the forces, but also the level of resistance that you will need if that task was being performed in real life. And that level of feedback was what we call the level of added difficulty compared to the other option that it was completely virtual reality. So when psychomotor precision is required, the tactile interaction, it really governs the idea of the educational value. That tactile interaction needs to be there. Now we're going to change pages and we're going to go to our second case study of the day. And this one is about a different procedure. It's called the twin-twin transfusion syndrome. So on the twin-twin transfusion syndrome, what happens is that when you have the two babies inside the placenta, one of the babies, in the normal case, the babies are sharing it in a fair way and they're both co-living. On the one on the right, what you guys can see is that all in a sudden there's a donor twin and a recipient twin. And this happens because the placenta is being shared, but there's some areas in the placenta where the nutrients from one twin, being the donor twin, is actually going to the recipient one. And unfortunately, this actually leads to fatality. So how do we fix it? The idea is you go while the patient is away, you go inside the belly, go down to the placenta, and with a laser, you cut those particular veins that are sharing some of the resources. But the main problem that we had with this particular case was that the literature shows that you need between 25 and 60 cases to actually master this skill. But in total, there's less than 20 cases performed annually by 50% of the global centers. So there's not really that many procedures that are happening, and you need a lot to be able to reach that level of expertise. So what we did an environmental scan, and what we found is that the main way that this procedure is being taught is through the health study model, C1, do one, teach one. And it's 2026, and we know that the health study model has some limitations. So clearly, for us, it was an opportunity of how can we improve this educational experience. And this brings us to how do we design the experiment? So we decided to compare, in this case, rather than creating two sims, we decided to compare the one that is available right now, that it was a physical mannequin to perform that skill, to a hybrid haptic simulator, similar to the one that we have done for the forces assisted vaginal delivery. On the physical mannequin, the mannequin looked like that. It was literally lifelike. You see the two fetuses in there, and then you will probe it with the stethoscope, and then be able to navigate it. The setup was done in the operating room, so it looked like very realistic, but the variations inside the womb weren't really as realistic as happened in real life. And then on our side, what we decided to do was using 3D printing, we developed a model that looked exactly like the mom's belly, with the different tools that are needed to complete the procedure. And on the other side, we also developed a virtual environment that replicated what the doctors will actually see on the screen as they are performing the procedure. The virtual environment has two levels. One that it was an entire operating room environment in which you have a smaller screen that is the one that will be showing what you need to do in the procedure, or you can just do it full screen as is shown in this slide. And this is how it will look. So you have someone working on the simulator, and the movements on the simulators, right now it's not in full screen on the laptop, but it will be shown in full screen. And that was the interaction that the participants were having. So what was our experiment here? We did 39 participants, 4 fetal therapists, then we have maternal fetal medicine specialists, and maternal fetal medicine fellows, and then OBGYN residents. Also a randomized counterbalance training in which the trainees will interact with the physical mannequin, complete some of the validated questionnaires, work with the hybrid simulator, complete it, and vice versa, alternated by a randomized order. And once we put our trainees, there was a 30-minute session, sorry, I forgot that. But once we put our trainees, what we realized is that similarly to our previous study, immersion and flow were very similar in both conditions, the traditional version and the version that we have developed. And when we look at the physical model, the data was very positively skewed towards perceived competence. I'll put a pin on that and I'll come back to it. When we look at the hybrid model, there was a spike significantly towards challenge and tension of the experience with the simulator. Now, on the shared baseline, it was the idea of the immersion and flow are the same. But if we go back to the idea of the perceived competence, I would like to bring here also some of the cognitive psychology work from Kroger and Dunning, where we know that we as humans perhaps are not the best at self-assessment. And sometimes when we believe that we are good at something and someone asks us if we are good, we might say like, no, we're not that good. So we underperform ourselves. Or we are perhaps not as good at something, but someone asks us like, how do you feel? You might overrate yourself. And that's a word that is coming from cognitive psychology. If we translate that into what we're seeing here, like the idea of the perceived competence we're seeing on the physical model is something that like needs further attention or further study. But if we saw that both simulators are perceived as equally in terms of realism and effectiveness, or in terms of immersion and flow, how do they alter the psychological reality of the trainee? Why one felt a lot more complex? Why the other one felt that there was a lot more competence? And on here, we started looking at all the different questionnaires that we have identified. And what we noticed is that when it comes to challenge and competence, yes, the hybrid was a lot more challenging and the trainees perceive a lot less competent. But our idea was like, how do we know why trainees are feeling less successful? So we also look at the level of affect. And we know that the hybrid simulator was actually created a higher negative affect. So a stress, frustration, and a negative affect compared to the traditional version of the simulation. And what we started realizing is that the simulation option that we have developed actually align more closer to the high stakes and pressure emotional environment when you do this procedure that I mentioned before, the patient has to be awake. And to further triangulate this within our data, we look at sensory and imaginative immersion and flow. Why those metrics? So the main element is that we wanted to say, well, is it that they are feeling that it's more challenging because the flow or the immersion is low? So that means that it's a problem with the technical portion of the simulator. But when we realize that the flow and the level of immersion are exactly the same, we know that the difficulty that we are seeing in the hybrid simulator is not an interface thing. It's actually more of a clinical element. Is the complexity in the clinical environment that the simulator is offering that is created that perceived a sense of difficulty for our trainees, which brings towards the end of my presentation. The main element for us was realizing that in both cases, on the force-assisted vaginal delivery with the challenges being able to complete the procedure, and also in the twin-twin transfusion syndrome, seeing a higher level of difficulty in the simulator that we have developed aligns quite well with the framework of desirable difficulty. And we know that through this framework, the first element is the cognitive demand. And what the hybrid simulator does in the twin-twin transfusion syndrome experiment is that it takes away any confidence that has not been earned. Like if the trainees are like, oh yeah, I know how to do this, the characteristics that the simulation is providing is taking that away from the trainee, which intrinsically will add more tension and more difficulty. And then we get to a level where like we reach that level of desirable difficulty that is provided by the system. But that allows actually for a deeper cognitive engagement with the experience, which then will help you develop stronger connections at a neurological level, and then having a higher rate of retention of that particular skill. All because you're able to realize what are your limitations and work through those limitations, which just kept us to the last step, that is the clinical readiness. Through that encounter of difficulty or challenges of productive failure, we actually see a trainee that is better prepared for the uncertainty, that this will bring in a real environment. This aligns with some of the educational work that underpins a lot of our educational practices currently in medicine, such as adaptive expertise and offline learning. All the educational enterprise that we have is really geared towards being able to prepare our trainees to be okay in those moments of uncertainty, because they are adaptive experts and they can change based on the different elements of expertise that they have into what they needed on content. So what does this all mean? Well, if I'm looking at the two cases that I presented, when we think about the TTTS and the forces-assisted simulator, we need to realize what are the demands that each of the procedure have. And on the first one, it was more cognitive and emotional. On the second one, it was more psychomotor and spatial. But because we understood that, we were able to then engineer that desirable difficulty. In the forces assisted, it was about that haptic resistance and being able to like train it on the psychomotor precision of placing the forceps. On the TTTS, it was about the stress exposure and knowing that every single movement can end up affecting the fetus. And then that gave us what we ended up using in our design solution. On the TTTS, a hybrid cognitive interface, and on the FAB, more of a 3D printer haptic interface, coupled with virtual reality. So what we're proposing is that the future simulation really takes away from all the noise that usually surrounds simulation when we think about fidelity. And we start thinking about a simulation experience that is driven by learning science, where we know about the different components that will help the simulation experience, and we have a clear target competence we're going to acquire, and the design is geared towards achieving that competence. So the value of a simulator is definitely not determined by the looks, but is how well it's designed to support learning. And that's everything that I have for today. Thank you.
Thank you so much, David. That was a brilliant presentation, and I hope that everybody is feeling as fired up as I am to ask you questions and to start what I hope will be a rich discussion. I want to say that you did an admirable job of representing your engineering background. I loved the way you designed your slides with that looked like blueprints and the I-beam. And that concept of, spanning, creating that infrastructure and that scaffolding for our trainees is so crucial. I also think that as someone who, at our Sim Center, which is focused on the mental health area, we also are grappling with effectiveness of virtual reality versus more traditional simulation methods, and this idea of high versus low fidelity. And going back to Lisa's response about it being context specific and depends, it depends. So, in the area of psychiatry and with interviews and interpersonal interactions, I guess the more realistic the encounter is, the more authentic the interaction is, that can actually, I think, create the challenge, the desirable difficulty, and the productive struggle that we need, as opposed to if it's a less realistic, say 2D kind of interaction. So I do think it depends on the skill sets that you're hoping to foster. We need to be thoughtful about how we integrate these tools. So I can
Okay.
help you moderate the chat if things get too exciting, David. So you're getting some thanks in the chat, and then I'm just looking. There's no questions yet. Does anybody want to ask or comment on David's wonderful presentation? So Fatima said in the chat, nice, impressive work. Mohammed is
Thanks,
asking
Fatima.
about your slides, whether they could be shared.
I think it will be part of the recording of this
Yes,
presentation, right? Yeah.
yes. So if you send Ricardo an email, and Ricardo will put his email in the chat, we can make the recording available to you. And then you'll be able to see the slides. So Fatima is asking, thank you for this insightful session. What simulation approaches do you think are most scalable and adaptable in low resource educational settings?
So if it's a low resource educational setting, I'll probably try to like connect this with the comment that Petal gave at the beginning of the Q&A. I will probably try to bring it down to what is the clinical demand that we're trying to achieve. So Petal was mentioning how like in psychiatry and particularly in mental health, like the idea of realism is important, and I don't disagree with her, but like I know that the clinical demand is different. Like the trainee itself has to like manage emotions, and the emotions like they need to be real, so you can actually like practice and be in the right place. On a low resource environment, one of the elements that I will say is, well, depending on the skill, like we have seen a variety of like innovative solutions. I know suturing is one of the most commonly used, but particularly because people were able to show the same element of expertise developed through using the traditional suturing simulators compared to using an orange or a tangerine, and then only try to do the suturing on the outside. So it really goes down to like what is the limit of clinical demand and what is the skill that we're trying to teach them. And suturing it works because really you're trying to show dexterity with the needle and the forceps, right? So that kind of level of like low fidelity will be helpful. But if we are thinking about like intravenous insertion, we might need something else because we need to make sure that we are able to hit the vein at the right level. So I will say that the most scalable one will be the one that use the little resources to be developed, but can address the clinical needs that you're interested in. How do you think people from different generation background are adapting differently with simulation design? Sana, if I understand the question correctly, it's not easy. And here it's kind of hard because I have Petal and Lisa who are uh, foundational on the simulation field, but I do believe that the change takes a little bit of advocacy. I think that there is still the feeling that, oh, we're gonna do a simulator, like, or we need a simulator, and they're looking at, the options that are out there commercially, and it's thinking like, oh, this one costs a lot, like maybe it's better or not, and that usually comes more from the top down rather than from the bottom up. Like I had the opportunity to work with Manzana skills training, lab simulation training lab years and years ago, and I know that they don't think about simulation, only think about fidelity. But similarly, I work with Michael Garron Hospital. From the bottom up, they don't think about fidelity in that particular way, but top down, like they do like the flashy things. They do like oh, we have this massive simulator, or like we just got this donation and we're gonna buy this super high fidelity piece. I think the conversation, I always try to drive it based on educational outcomes. So they might not be as open at the beginning, but I think like no one can argue with data, and if you know that you're bringing something useful, uh, that might help us. That something useful that might overcome the conversation. I see Fatima mentioning what challenges shape that passion, I believe.
Did she,
Uh,
or is it passion or position? I'm not sure. Maybe passion, yeah.
I, I just thought
Yeah, passion.
passion.
Yeah.
Okay. Uh, oof, what challenges shape that passion? I think many. I think like something that happens when we start working with simulation, and here I'm not going to focus only on medical, but health professions simulation, is that we always want the simulator to work. I think that's the baseline. Nobody tries to work with a simulator that doesn't work. But given all these different factors that we talked about it today that influence this idea of work, sometimes you run an experiment, it doesn't give you the data that you want, and an experiment that doesn't show the results that you're expecting. I think that is quite challenging, and sometimes being able to translate that to the different pieces. As an engineer working in medicine, I was able to speak to both worlds, but I know the engineering developer teams sometimes don't speak the same language as the medical experts, and there's sometimes some tensions when it comes to development, testing, and validation. So I'll see it on those two levels. Like not everything is going to be positive results, and there's going to be a lot of communication, not only on the ones that are developing the simulators, but the lab technicians, your simulation specialists, like everyone in the system needs to be aligned. Otherwise, those disconnections is sometimes what prevents us from doing the good work. And Fatima has shared what design elements are more important to ensure that low resource simulation remain effective in developing clinical reasoning. Fatima, I actually believe that on that case, if the main element is about being effective, I'll probably link it to feedback and making sure that you continue to make sure that it's actually reaching the right goal. Engagement on the simulator is great, but as McGee showed, like we need a structure with the practice, and the structure with the practice alone is not enough because we need the feedback. So in a low resource environment, the one element that I will say is if you give, using my same analogy with the orange, to someone that is practicing suturing, they're going to do it a few times and they're going to get bored and then they're going to go. But if they do it a few times and they have someone that says like, actually this didn't work, like the incision wasn't as good, like you need to check the angle, like all these other elements, even though I understand that it takes resources, I think it can help a lot with making sure that it remains effective in developing that those skills. When it comes for clinical reasoning, clinical reasoning is quite wide. So I don't want to give a blanket statement of one educational design that helps with clinical reasoning, but definitely clinical reasoning, I bring it always down to adaptive expertise and this idea of being familiar with uncertainty. So at that point, I would probably think about variability on the different scenarios of training. So that way you're not training on a single scenario, but you're training in a multiple one. And what the theory, educational theory says is that by having that multiple sampling, then you will be able to be better prepared in the moment to address it in the real world.
David, Lisa's hand is up.
Well, hi, David. Nice to see you again.
Hi, Lisa.
Hi. I think you may have answered a little bit of my question, but now with all the new dynamics and simulators that are out there, be it high or low fidelity, how important is personal feedback versus computerized feedback when developing the simulators? I know that you just explained with the orange that having feedback, otherwise it becomes
Mm-hmm.
boring. But even with the sophisticated simulators, I find them directional towards trying to make them as independent as possible, not only from practice, but also from a feedback perspective, so that clinicians' time can be spent with patients and reduce maybe one-on-one teaching. How are we moving better with feedback from AI, computer generated, what have you, versus still the personalized clinical interpretation of the practice on the simulator?
Thanks, Lisa. That's a great question, particularly because you're right. I think there's a lot of companies nowadays that are thinking about independent feedback, and particularly with AI, like it makes it a lot more attainable. I think for me, the main difference between independent, like if we go back to like the 2010s when like they were doing all this work in simulation, people will talk about objective versus subjective feedback. For some reason, we had this idea that objective was the machine and subjective was the physician, and then like, oh, we're just getting subjective feedback. So I think those rhetorics has augmented this idea of like, oh, maybe more objective feedback is better. But I do worry that uh, there still hasn't been like a characterization of what are the elements of feedback that faculty provides on each procedure. And I do believe that sometimes the feedback goes beyond the traditional skill for that procedure. If they are handling something wrong and the faculty notice that it's probably not just handling something wrong, but there's something else, then faculty can actually give you that. What I know the limitation right now with technology is that the technology will tell you you might be handling it wrong, but it might not be able to tell you why you might be handling it wrong because, and again, based on the current state of the art, the experience that the faculty has of, oh, I've seen that problem before and I know it might be this, that's the one that the model might not have at the moment. So I I do believe that if we're thinking about the low resource environments, this idea of AI augmented objective feedback might help bridge the gap between like low middle income countries and high income countries. But I also understand that it's not the solution for all, and there's a lot of context specificity and uniqueness that human feedback actually bring into experience.
David, in your slides, you mentioned parameters that you assessed, like cognitive load. Can you expand a bit more on how you measured cognitive load, like qualitatively,
So
quantitatively?
thank you, Pedal. That's a great question. So the idea with cognitive load, If someone from the Boston Center was here, they'll probably be laughing because I'm a critic of cognitive load because I do believe that cognitive load is very good at explaining what happens in the head, but like we haven't been able to measure it. So we went from some work that we did back in the 2010s with Faisal Haji around like trying to measure the cognitive load and adding some elements of difficulty and trying to capture it. And we realized that it's very hard to remove the germane from the intrinsic and the extrinsic. And what I see nowadays that I finish my PhD, came back into the simulation world, is that now it's a composite and it's usually measured by a survey. So it's a questionnaire after that they just completed, and then they give me a composite of like, this is your cognitive load. Eh, I know it's been validated, so that's why we use it in our analysis. But for me, the critique stays, and is I don't know what of the loads is overdoing. Is it the germane that is the one that they really do have, or the intrinsic or the extrinsic? Like, well, what is really the piece that is not working? So I think it goes back to a little bit of what I was talking to Lisa. Eh, Sometimes we focus so much on the tangible piece that we can see that we don't understand, or perhaps we don't see it like, oh, tell me why is this working. It's working, that's great, but I think there's a lot of the why or the how cognitive work happens that I'm like, I don't know, like the tools are useful because it shows differences, but I would love if we were able to capture it more at a more disentangled level.
Mm-hmm. Because, like you said, we want to create uncertainty to build adaptive expertise. So that's sort of inherent in creating cognitive load too. So,
Mm-hmm.
yeah,
And we still doesn't our interesting project we should call Maria into it, because there's an element of desirable difficulty and cognitive load. And
mm-hmm.
then how do you pair desirable difficulty with cognitive load to be able to read the outcome that you want? I think like, yeah, there's just a lot of work to do in simulation, especially with all the new additions that we have nowadays.
Absolutely. And we're right here on the hour at 1 o'clock. And this has been a fabulous presentation, David. You are definitely coming back to SimCity Rounds. And
Anytime, I'll be
we,
happy.
we thank all of you for making the time to attend today. And we'll see you in May when we have Dr. Claire Jones presenting to us. So take care and have a great rest of your week.
Thank you.